Good evening, ladies and gentlemen, dear chair members, dear colleagues. It's a great pleasure for me to talk in this audience today and to present you some of our latest findings we got in Basel regarding BMP10, a novel cardiac-specific biomarker in acute dyspnea in patients with acute heart failure. Acute dyspnea is a very common medical entity, as we all know, and it accounts for up to 4 million emergency department visits worldwide. And 1 out of 2 of these patients actually suffer from acute heart failure. The mortality of acute heart failure patients, if they already reach a decompensation and ended up in an emergency room, is very high and reaches up to 30%. Accurate diagnostics and good prognostication could enable us to tailor our therapies in order to improve outcome of these patients that are currently experiencing these adverse events. Well, when we speak about diagnostics, we know that natriuretic peptides are now the standard of care, and they are excellent or near excellent tools enabling us to identify acute heart failure patients from that pool of acute dyspnea population. However, there is a specific patient population, so those patients that suffer from acute heart failure and have a concomitant atrial fibrillation. They are different and they are difficult to identify, and the diagnostic power of our current biomarkers is much worse in these patients. We also know that the patients we are seeing in our emergency departments, they feature different risks. We have those patients that have low mortality and subsequent hospitalization risk, and we have those high-risk patients. Well, it's not easy to identify who is who, but a theoretical approach could be that we should tailor our therapies based on that risk, although not proven in randomized trials or very superficially tested. That could improve outcome of our patients. However, in daily clinical practice, the absence of good and reliable risk prediction tools make that these patients with very different risk profiles end up in very different settings. And this probably contributes to the poor outcome of the patients suffering from acute heart failure. And this is nicely illustrated by a recently published randomized trial in the New England that showed that 1 out of 3 high-risk patients is discharged from the hospital within 3 days when the decision regarding the risk is based on clinical judgment. Very recently, a novel blood biomarker, BMP10, has been introduced to the research arena. Well, BMP10 is an atrial-specific biomarker, and it is believed to be expressed in the right atrium, and it is a biologically active molecule, meaning that it has biological effects, including the myocardium. When working intracardially, BMP10 preserves cardiac function and inhibits cardiac cell death and fibrosis. Also, when secreted into systemic circulation, BMP acts into vascular system by maintaining vascular function, reducing permeability. Also, it works in the regulation of lymphatic vessel maturation. It can cause vasoconstriction, and it is an anti-inflammatory molecule. Well, based on these pathophysiological assumptions, we made an hypothesis that BMP10 can assist us in acute heart failure diagnostics and prognostication. To check this hypothesis, we analyzed the BMP10 in 972 acute dyspnea patients from Basel V study. This biomarker was analyzed in consecutive patients, avoiding selection bias. Basel V is a large study with central adjudication not only for the reason for acute dyspnea, but also for the phenotypes and triggering factors. The following analysis I will present you have 2 parts. So the first part is the diagnostic analysis that excluded 39 patients for some sub-study specific reasons that I will not elaborate in more detail because of the lack of time, and the prognostic analysis that included acute heart failure patients only. We had the data for echocardiography regarding atrial sizes in a limited proportion of our patients. So the baseline characteristics of the diagnostic population were as follows. The age was 77 years, 45% were female, and atrial fibrillation was found in 1 out of 3 of these acute dyspnea patients. When speaking about acute heart failure diagnostics, as one could expect, BMP10 did not outperform NT-proBNP in diagnosing acute heart failure. Also, the combination of both biomarkers together did not significantly improve the area under the curve for acute heart failure diagnostics. Well, the main question for us that we were very interested in was whether BMP10 could help us in diagnosing acute heart failure in this difficult scenario I presented previously. And here we found that the areas under the curve for BMP10 and NT-proBNP were not significantly different. And the combination of both biomarkers, again, did not significantly improve the area under the curve. Although we have limited data on the atrial size, we still checked whether BMP10 could work better in patients with right and left atrial enlargement, and their BMP10 performed equally the same as NT-proBNP, with the areas under the curve being similar. And the combinations, again, did not improve the diagnostic accuracy significantly. As I told, Basel V clinical study has extensive phenotyping and triggering factor adjudication. And we checked whether BMP10 could let us predict whether the patient came for acute heart failure that was triggered with acute arrhythmia. And here, very interestingly, BMP10 actually outperformed the giant NT-proBNP, and this we've seen very rarely in biomarker arena, when a new biomarker could outperform the long-standing and a well-established molecule in this diagnostic setting. Here, the combination of both biomarkers, again, did not improve this diagnostic accuracy for arrhythmia-triggered acute heart failure. As I told, it's very important to improve our abilities to prognostify acute heart failure patients, because this has a potential, after appropriate interventional trials, to improve our management pathways. And here we've seen that the higher the BMP10 concentration is, the worse is the survival. And patients in the first quartile, the green Kaplan-Meier curve, had the best, and patients in the fourth had the worst outcome. However, after extensive multivariable adjustment with other co-founders that were validated in risk prediction models for heart failure, we found that BMP10 was no longer a significant predictor of outcome. We also did a fraction of new information analysis, and there BMP10 added only 0.1%, meaning that it added nothing to this model that is outlined on the slide. The similar story was found with heart failure hospitalization pre-survival, and here again, the higher the concentration, the worse is the outcome. But multivariable adjustment again showed that BMP10 was not an independent predictor. This study has, of course, several limitations. Well, first, the study was a European study, and we could not elaborate more on racial differences. Also, a strong limitation is that natriuretic peptides were used for central adjudication, meaning that the one-to-one comparison is difficult and has this limitation, and we have to keep that in mind. This study excluded patients on dialysis and on those that did not provide informed consent, and these patients are very often very difficult patients where blood biomarkers could add even more than in a usual setting. But again, we did not have these patients in Basel V clinical trial. And again, the sample size for echocardiographic measurements were small. Well, ladies and gentlemen, let me finish my talk by concluding that biomarker-based acute heart failure diagnostics is challenging when atrial fibrillation is present. BMP10 is inferior to NT-proBNP in diagnosing acute heart failure, and the combination of both biomarkers does not improve diagnostic power. However, BMP10 is superior to NT-proBNP in predicting arrhythmia-triggered acute heart failure cases. Acute heart failure patients with increased plasma BMP concentration are actually at increased risk of adverse events. However, this prognostic power was lost after multivariable adjustment. And with this, I want to finally finish my talk, and thank you for your attention, and I look forward to any discussion we might have.
Yeah, also very nice presentation, very nice and clear data. Yeah. Honestly, I understand your conclusion with a p-value of 0.02 for arrhythmia-triggered heart failure, but honestly, I was not so convinced when I saw the REC curve. So honestly, they were...
For the triggering factor?
Yeah, for arrhythmia-triggered heart failure. So
yes.
You mentioned that this was a p-value of 0.02. It was better than BMP, but the curves were nevertheless nearly overlying. Yeah.
No, we could check it. Well, for me, it looked quite convincing.
Okay. All right.
I don't know if we could see it again, but.
And maybe before we have another look on this specific slide, do you have any explanation why the combination in particular, maybe go back, yeah, so
yeah. Sure.
Look for this. So yeah, it's for sure there's a difference, but not sure if it's a huge difference. Any explanation why the combination in particular in this setting is not better? So usually if you combine two markers in this setting, usually you will turn out with a better RSC curve. So that's the reason it was a little bit surprised to see this.
Look at the confidence interval.
Yes, the confidence intervals is the statistical background why it is. The clinical background is quite difficult to elaborate, I must say. Yes, the confidence intervals are those that show why this is like this, but how can we interpret it from clinical point of view? It's a difficult question.
Yeah. Probably the p-value of 0.02 will not be sufficient to get into the guidelines. Also for the use of this marker in the clinical setting.
I think that our data is of exploratory purpose still, and we of course need more data on this very new biomarker, but the other studies we have from atrial fibrillation cohorts bring us quite exciting results, and yeah, I'm very interested in and look forward to see what else we will hear in the future regarding BMP10 and arrhythmic patients.
Okay, thank you very much. So at least your last slide was not a German beer. So now we move on to the to the next presentation. Thank you very much.